So everybody can hear me. Thank you for your patience. We have some technical difficulty. So we're running a little bit behind. I'm going to focus my talk today on interventional cardiology during the coronavirus pandemic. I want to give a shout out to Randy, who really helped with this presentation and did some, a lot of research and videos. So thank you, Randy, for your help. Next. Patrick? Good. No disclosure here. Next. So the objective of my presentation today, I'm going to discuss a little bit updated management of STEMI and non-STEMI during this outbreak, and talk about triage guidelines for elective versus urgent procedure, and spend some time talking about resuscitation of COVID patients. There have been a lot of discussion about that. Finally, the donning and doffing procedures, I will share a video with you. I think you will find helpful. I don't know if I can, maybe, I'm not sure what the technical difficulty we're having, but I will be able to do it or not. Go ahead, next. Principles for establishing those guidelines. Essentially, we want to reduce patient risk for acquiring COVID-19 when they come to the hospital. Minimize healthcare worker exposures, and with the shortage of PPE, we try to have as much PPE as we can to be able to care for patients during the outbreak. Finally, we want to make sure we provide care to our patients who are already have established COVID-19 infection. Okay. So this is a busy slide, but the Canadian Association of Interventional Cardiology with essentially a table to help programs prioritize the procedure on patients during the outbreak. And the interesting part about it, they essentially put three categories for programs. When they have a minor restriction of regular services, what kind of procedure they need to do, what kind of care they can provide. Second is, the second stage is when there's a major restriction of regular services. I think that maybe fall in this category. And the third is when there's complete inability to provide services because of because of extreme limited resources of staff and PPE. So it's a very thoughtful approach, because honestly, applies to a hospital in Brooklyn right now today is different than what applies to us. I mean, the difference in the amount of patients with COVID-19 and the resources available. You know, we have hospitals in New York with 90% of their patients have a COVID-19. I just talked to a physician yesterday on the phone. They have right now 150 patients with COVID-19. So the restriction of procedures that need to be done, the elective procedure and semi-elective, completely different between these type of hospitals and, for example, our existing hospital. And it's a fluid situation. What applies today to Baptist may not apply to us 2 weeks from now when the outbreak hits, if it hits. So I don't want to go through this entire chart, but it just gives you an idea about how hospitals around the country with this, how the guidelines is evolving. What applies to certain regions does not apply to the other regions. So there need to be discussion and evaluation regarding that. Next. Similarly, what applies regarding heart cases, TAVI, mitral clip, ASD, Watchman, that's that might vary a little bit according to the restriction. So these are the Canadian guidelines. I just wanted to kind of show it to you, share it with you, because it's very thoughtful in terms of the regional management regarding to the regional distribution of the disease. Next. So these are the first guidelines out from the American College of Cardiology and Interventional Society, SCAI, essentially to help provide some guidelines, some direction to all of us about how to deal with this crisis. And it was just published, I think, 2-3 weeks ago. Go ahead. Next. So the thing is, the cath lab consideration that we need to keep in mind. Next. You know, all cases of suspected COVID-19 should be treated like a confirmed cases. Unfortunately, we don't have the ultra-rapid testing at this time available. So instead of having to wait for those cases, we have to assume that when someone is under Can you hear me?
We can now.
Okay, sorry, technical difficulty. Next. There has to be a strict running and Doffing protocol in place to deal with those patients. Next. Usually it's suggested 1 hour delay after the done before terminal cleaning takes place. And the reason for that is essentially there is the aerosolized virus can stay in the atmosphere up to 1 hour. So they usually, after the room is closed, nobody goes in and out till for an hour before terminal clean of the case is done. Go ahead. Next. So ideally, those cases should be done the last case of the day to minimize cross-contamination. Next. And we have done essentially in our cath lab, we designated a single room, single cath lab for all potentially COVID cases. It's a good idea not to sort of spread that and bring these patients to different rooms. So one case, preferably at the last case of the day. One room, preferably the last of the day. Next. And there may be some protocol in place regarding transportation of those patients, but that needs to be articulated and clear, how to transport the patient from the floor or the unit to the cath lab. And, you know, every team member should be comfortable and aware of this protocol. Next. In some parts of the country, they now require testing of all patients that coming to the cath or EP lab, making sure to know whether they're COVID positive or negative. We haven't done that in our institution, but something to consider, especially if the incidence of the disease increase in our region. So essentially it'll help even asymptomatic patients coming in for routine cath. They might be asymptomatic carrier essentially. And so prior testing of all patients may be considered in some region based on the degree or the incidence of the disease. Next. So what about elective cases? Well, obviously, decision is decisions and must be individualized. However, typically, it's not recommended to do PCI, for example, on stable ischemic disease patient, asymptomatic, and patients who have claudication, maybe delay the procedure for time being. There's a whole host of procedures that now put on the back burner, and essentially the outpatient scheduling needs to be individualized based on the acuity of the presentation of the patient and the symptomatology. So for example, today we did case on someone who's having active chest pain, outpatient. Obviously those patients, even though they're outpatient, need to be scheduled. On the other hand, we have all of us sort of postponed some cases with positive stress tests who are asymptomatic. Next. So what about STEMI? Let's talk a little bit about the background. Go ahead. Next. The primary PCI, is currently the routine method in the U.S. for dealing with STEMI patients. Next. Rapid testing, unfortunately, is not available, which means patient coming from the ER and you have to bring him immediately to the cath lab. Anytime you don't know if they're positive or negative. That plays even bigger role in places like New York or Washington, where the prevalence of disease is quite high. So for those patients, essentially, in these locations, everybody gets treated like they have positive COVID-19. As you're all aware, there will be some rapid testing that hopefully we will get it soon that might help delineate that. But my understanding, even the rapid testing can take an hour before we get a result. So I'm not sure how it's going to be relevant in terms of the STEMI cases. Next. Certainly the benefit of PCI in COVID patients need to be balanced. The potential risk of staph exposure. Furthermore, the futility of the procedure. So you may get somebody with who admitted with COVID-19, who have severe pulmonary disease, quite near the end stage part, and some of them will have ST elevation. You got to think about the futility, even if you take the patient, bring him to the lab, put everybody potentially to the virus. At the same time, really, the outcome and the prognosis is dictated by COVID-19 infection, by STEMI. And we'll talk about that in a little bit. Next. In China, I reviewed the protocol where during the crisis, they didn't do any more, any primary PCI. They reserve it as a second choice. And essentially, fibrinolysis was the primary method of revascularization of STEMI patients during the outbreak. That was pretty much done throughout, and left the primary PCI or rescue PCI in cases where there is a patient failed thrombolysis and cardiogenic shock, etc., but not as a primary routine method of revascularization. Next. So is it fibrinolysis? Is it angioplasty? Which one is better? I mean, that discussion may be not relevant in COVID-19 era. To me, they're more complementary to each other rather than competitive therapy. Next. So we discussed about potentially primary angioplasty as I have to weigh that patient benefit that from this procedure versus the potential risk of staph exposure. Next. Next. So how do we treat during COVID-19 pandemic? This is sets of guidelines essentially were just about to be published from the Society on Geography as well as the American College of Emergency Physicians. Next. These guidelines establish a set of protocol to deal with our patient with STEMI and potentially COVID positive. In essence, I don't want to spend too much time going through the diagram, but in essence, the important that they utilize echocardiogram frequently for establishing whether a patient has regional wall motion abnormality respond with STEMI or not, and that might be helped to confirm because there's frequently you have ST elevation and not necessarily STEMI in those patients. So if they have confirmed classic presentation of STEMI and with possibly wall motion abnormalities on the echo, and everything seems to indicate that the primary angioplasty continue to be the way to go. I'm sorry, the part of the slide is cut at the bottom. I don't know if you got it or not, but it says primary angioplasty at the bottom. If the symptoms, even though there's ST elevation, the symptoms equivocal, EKG is not very clear cut. Again, echocardiogram might be of value. Looking at chest X-ray, the patient, this is a COVID condition. Is this maybe he has COVID-19 myocarditis? These type of things need to be thoughtful discussion and evaluation of the patient. So it's not a knee-jerk reaction. Every elevation needs to come to the cath lab. Next. Similarly, this is it goes into patient present with the STEMI by EMS. Again, it requires further evaluation of the HMP and assessment. They're here suggesting ultra-rapid COVID testing. Fortunately, we don't have it here, so it's not relevant to our situation. But hopefully, it will be soon available. And they're talking about essentially what to do. In general, their recommendation, everybody, the team should have a full universal use of PPE, assuming whether they're COVID positive, COVID negative, because since we don't know the answer to that, we assume they're possibly COVID positive. And they recommend full-fledged donning and doffing protocol as if they are positive for COVID-19. Next. Here, the further discussion, what about patients presenting with STEMI or from J or Atmore, gluten, etc. Obviously, depending on the transportation time, they encourage the use of fibrinolysis in those patients and reassessing the patient upon arrival and looking, about the issue whether they test the patient, ultra-rapid testing, and looking to see if they're positive or negative. And if it's positive, you gotta have to think about, is this myocarditis or other causes for that elevation, or is this true STEMI? If it's true STEMI and the patient has has successful thrombolysis, then essentially wait on those patients for at least 24 hours, get the result of the COVID assessment prior to taking them to the lab. If they fail the fibrinolysis and they look like they're not doing well, then think about maybe taking them to the lab and fixing them. Next. So this is kind of summary of the guidelines. It's a long document, but in essence, in a nutshell, that's the summary of it. Next. So what's happening around the country? It's interesting phenomena that took place that was first described in China and then Italy and the rest of the world, and now we're experiencing the same phenomena here. There has been reduction in STEMI cases and throughout the world. And you might wonder, like that, is COVID-19 cardiac protective? No, absolutely not. We know the complete opposite. And there's many theories behind what's the cause for that reduction. Go ahead, next. So this study actually, before you go next, let's go back, please. This study looked at the number of the 9 largest cardiac program around the country, from General Hospital, William Beaumont, to Swedish Medical Center, etc. And they looked at the number. So essentially, it's a small sample, but it may be reflective about what's going on around the country. And they looked at the number of STEMI before and after the pandemic. Go ahead, or during the pandemic, I should say. Next. So you see here, oh, I think you may have skipped back. Yeah, here we go. No, next. Okay. So these are the location of those centers. And the average STEMI activation per month, per site, was around 23. And after COVID-19, it's down to 15. So somewhere around 30%, 40% reduction in number of STEMI during the COVID-19 crisis. And again, there's many potential explanation, but it's too scared man. You know, I have more than 53 years old, just then, you know, so he said, well, thank God, because I was scared it's coronavirus. I was scared to go to the hospital. So that's kind of reflective of the mindset. People don't want to come to the hospital. I never imagined my entire life hearing somebody saying, thank God it's like not coronavirus. But here we are. People are sort of scared to come to the hospital because of the risk of the infection. So many people, they're infarcting at home. And we're going to have, I would suspect we're going to see maybe increase in the number of congestive heart failure cases and chronic total occlusion, etc. in the ensuing months, because you know people are going to suffer through the heart attack and essentially instead of coming to the hospital. So there has, and with nations telling them, please, if you start having chest pain, come to the hospital. Chances of dying from attack far outweigh contracting COVID-19. Just to be clear to the rest of the community, I think. But with all the noise right in here, this message is not registering. Next. Next. So go back please. Our study that came recently published, I think maybe last week, in New England Journal of Medicine. It's a small study. There are reported 18 patients with STEMI who happen to be positive with COVID-19. 10 patients on patient, they had STEMI, and 8 developed STEMI while they're in the hospital. Only half, believe it or not, half of those patients underwent cardiac cath. This study was done in NYU, so it's big practice center. And out of the 50% that underwent cardiac cath, meaning 9 patients, only 6 had obstructive CAD, 5 required PCI. So really the incidence of obstructive coronary artery disease is way far lower if the patient has COVID-19 than if the patient does not have COVID-19. And essentially that's sort of the take-home message from this. Next. So elevated troponin is quite common with COVID patient. Roughly around 7% of the patients with COVID-19 have concomitant cardiac involvement. We know that essentially elevated troponin with COVID-19 positive, that means worse outcome. That has been shown. And there's many reasons why troponin in those patients. Next. So it's a combination of things. I think it's possibly related to type 2 MI, hypoxic injury, supply-demand mismatch. We heard about, essentially changes in the hemoglobin and the releasing of iron, etc., where essentially there's hypoxemia. Next. Some of those patients have myocarditis. Dr. Godot talked about this. And the virus has predilection to attack cardiac myocytes. So you get release on that basis as well. Next. Coronary spasm. Next. Takotsubo cardiomyopathy. This has all been described in patients with COVID-19. Next. And finally, type 1 MI, rupture plaque, which appears far less common in COVID patients than non-COVID patients. So, when you get elevated troponin, the first thing comes to our mind is this type 1 MI in COVID patients. In COVID patients, it really should be a little bit lower on our differential diagnosis. Next. So non-STEMI patients with COVID positive, what do we do? Next. We know there's, like I said, 7% risk of type 2 MI or myocarditis, those patients. Next. If possible, patient coming in presenting with non-STEMI, it's recommended that to wait for the test. Most of those patients are relatively stable. They're on the floor or, and hemodynamically stable. It's ideal to wait the results instead of pushing them to the catheter. Right. Next. So medical therapy, conservative therapy is first-line therapy instead of aggressive invasive therapy in those patients because of lower chance of coronary artery disease in those patients, plus the risk of exposure. Invasive therapy is only recommended with COVID positive patients for high risk type 1 MI with showing evidence of hemodynamic electrical instability. Those patients still need to come to the cath lab. The majority of them can be treated conservatively. They should be treated conservatively without invasive therapy. Next. So this is another set of guidelines that came out also last month, I believe. It's a consideration for triage for patients referred for structural heart or intervention during COVID epidemic. Next. So the most important one is the aortic stenosis. Obviously, some of those aortic valve stenosis patients need to have the TAVR procedure done with urgency. Essentially, the symptomatic severe aortic valve stenosis, it falls into 3 categories. We have the symptomatic severe AS, the minimally symptomatic severe AS or critical AS, and we have the asymptomatic one. So each one of them, I think we should approach them differently. Next. If you look at the symptomatic aortic valve stenosis, oops. Patrick, you okay?
Yeah, it keeps glitching. I apologize.
Okay. So the symptomatic AS, essentially those patients who happen to be inpatient and severe AS, they have class 3 or 4 congestive heart failure, they have or patients who are presenting with syncope related to critical AS. Patients who have critical AS with reduced ejection fraction, those should be treated without delay, even during the pandemic. For the outpatient, patients who present with class 3, class 4 heart failure or syncope, they should be treated without a delay. Next. What about the minimally symptomatic, severe or critical AS? Those patients should be considered for treatment are the ones very high Vmax, that means more than 5 meters per second, very high mean gradient, typically more than 50, and very low aortic valve area, is less than 0.7 or less. Those patients should be considered because of potential harm for excessive delay. And obviously, this group of patients, treatment should be individualized. If we defer those treatment for those patients, obviously those patients need to be followed on weekly basis with contacting the patient, making sure they're doing well and their clinical conditions not deteriorating. Next. The asymptomatic patient with severe critical AS. Can we show the slide? Usually, they're, regardless if they're completely asymptomatic, those cases should be deferred at this time. But weekly check-in, and if they start deteriorating, they need to be prioritized. Next. TAVR clinic consideration during COVID-19. It's important to have the clinic schedule despite the pandemic, and use freely the telehealth option. Now we have it here to contact those patients on a weekly basis and making sure they're doing well and their condition is not deteriorating. Next. Next. So what other cases that need to be deferred? For example, the PFO ASD closure, all these cases need to be deferred at this time till the pandemic is completely over. Those patients are typically stable. Next. Watchmen, they are typically recommended that should be deferred, all of them, till after the pandemic. Next. Alcohol ablation for hypertrophic cardiomyopathy. Next. Paravalvular leak closure, delayed except unless they really failed medical therapy and they're back in the hospital with congestive heart failure. Next. Another clip, typically deferred, but with the exception, some of those congestive heart failure patients who really cannot be stabilized medically, they need to be prioritized, but routine mitral clip, they typically recommend that be deferred. Next. So what about resuscitation? So I heard all these stories from people say, well, nobody with 19 should be resuscitated, etc. I think I don't really see a clear guideline in terms of not resuscitate COVID-19 patients. So that's out of the window. I want to hear people talk about it. However, Everything needs to be done in the context of patient clinical outcome and presentation. Few things need to be kept in mind. Our rooms in the lab in the EU are not negative ventilation. We are not really well equipped to handle intubation and suctioning and bagging in the cath lab. That's really posed very high of aerosolization and staph exposure and infection. So all the effort ideally should be done in like rooms with negative ventilation, either in ICU or in the emergency room, not cath lab. So patients coming to the cath lab or EP lab, and if they have marginal respiratory condition, maybe ideally to be intubated in the ER before bringing the patient to the cath lab. In the ER, they're much more equipped and they have a negative, which we don't have here. The last thing we want to do is intubate the patient or doing bagging and suctioning while that's sort of recipe for disaster, and almost everywhere in the guidelines they do try to avoid that as much as possible. So I just want to make sure that sort of everybody understands this. If there is a need for, if the patient's marginal respiratory status, deal with it before they come to the cath lab, not while they're in the cath lab. Next. So donning and doffing, obviously everybody should be fitted by now N95 mask. And if you're not, please reach out to your supervisor. There's a place in the hospital where they fit you, make sure that, and they test you, make sure that N95 is well fitted. Next. I'll talk about that in a little bit. There has to be a trained sort of individuals that help oversee the donning and doffing protocol that takes place in the lab. Next. So essentially identify staff champions and train, because this stepwise approach that need to take place as you're putting on your clothes or taking them off. And you're going to have to go step by step. And trust me, it's a lengthy one. So it's not something you'll memorize or you can wing it. It's not. So there has to be some staff trained to do this who can read out the instructions step by step, how to put on your clothes and how to take them off. Next. Keep in mind, we are healthcare worker force multipliers. If one of us goes out or some of us goes out, that really affects so many. So you got to think about how really to protect yourself. Loss of healthcare workers in a crisis is really catastrophic to the institution and to our community. So keep that in mind. Your safety is very important, especially these days. It's important every day, but especially at the time of the crisis, because every staff worker gets infected, quarantine. It's not only quarantine himself, but there's everybody else's staff around him who was in contact with him. So we're talking about there's some institution, you all heard about it, some of them like 250, 300 of their healthcare workers got quarantined because of lack of very strict protocol. So your protection is critically important these days. So I'll leave you with this essentially. We're going to get through this. Tough time has been rough for everyone. We're going to get through it, and it's going to be bright and shiny on the other end. Just thank you, all of you, for everything you guys been doing. You've been very helpful during this crisis. You've been very patient. But I think we'll start seeing the light at the end of the tunnel. So I'm hopeful in in next few weeks. We're going to be, is this all going to be, any other questions?
Thank you so much, Dr. Jaalouk. I'm going to pull up the chat. I'm not seeing any questions there. I'm going to go ahead and unmute everyone.
Thank you so much.
Okay, so all right, I tried unmuting you all, but there's a lot of talking. So if anyone has any more questions for Dr. Jaalouk, please unmute yourself. Go ahead and ask any questions you may have. But if not, that may be it for one new miss. And if anyone wants to pull up the video that we were referencing, it looks like Randy put it into the chat, and it's 21 minutes in. So you can go ahead and check that out. But I think that may be it. Thank you so much, Dr. Jaalouk. I really appreciate it, and have a great day, everybody.